Welcome, everyone. We're just going to give a few minutes for everyone to join today's session. While you're waiting, please feel free to share in the chat where you're coming from, so what your background is and your location. Okay, we're going to get started. I'll start by introducing myself. So my name is Julia Kujaba, and I am a member of the Health Promotion Ontario Professional Development Subcommittee. I'm also a member of HPO's Executive Committee. And so today we're thrilled to have you join us for our session, which is Health Promotion in a New Era, Skills We Need for a Changing World. That's our overall series, but our session today is called Coming to the Table. So it's all about intersectoral collaboration. So today we're going to get started with a land acknowledgement. Today I am meeting virtually with you from Algonquin Anishinaabe territory, or what we know as Ottawa, Ontario. I respectfully acknowledge that I'm on the traditional territory of the Algonquin Anishinaabe, who have lived here for millennia. We offer our gratitude to the First Nations for their care and teaching about our earth and our relations. May we honor those teachings. This session is made possible by our wonderful Professional Development Subcommittee, as well as the Ontario Public Health Association and Health Promotion Ontario. As the voice of health promotion across the province, HPO seeks to advance the importance of health promotion through professional development, member communication, and advocacy. We encourage you to consider becoming a member today. So we're now going to go through a few housekeeping items before we get started. The session is being recorded. It will be available on the HPO website later on this month for your convenience. So the previous session was recorded as well, and that's going to be sent out to everyone who registered tomorrow. And so likewise, this one is going to be sent out likely next week. So we do encourage you, as you are listening to the presentation today, as you're coming up with questions, to please submit those questions using the Q&A tool, as well as participate in any discussion using the chat tool. So questions, Q&A tool, and then any other kind of conversation or comments, put that in the chat. And our session today is going to be structured in 3 sections. So what we're going to start with is a brief presentation from our speakers. You can see here are our speakers, which I will introduce in a moment. We're then going to move to panelist discussion, and then finally we'll end with the audience question and answer. So we'll again encourage you to submit those questions throughout as we'll be compiling them, and then we'll be able to answer them during the later portion. So now moving on to introduce our speakers. We have 4 speakers today. So Natasha Baudin, she's worked with the Community Health Center for almost 20 years. She most recently worked as a health promoter at the Centertown Community Health Center in Ottawa, and has worked in the areas of food security, smoking cessation, stress reduction, and physical activity, as well as leading the social prescribing project for the center. She chaired the Health Promotion Network of Eastern Ontario for the past few years and is currently the lead on social prescribing for the Alliance for Healthier Communities. Dr. John Puxty is our second panelist. He's a geriatrician, associate professor, and chair of the Division of Geriatric Medicine at Queen's University. He's also director for Center of Studies in Aging and Health and Southwestern Ontario Regional Geriatric Program. He has a primary interest in promoting healthy aging and wellness for older adults through ongoing research in aging, age-friendly communities, memory disorders, and knowledge mobilization strategies. Moving now to Jessica Austin. She's a health promoter with Southwestern Public Health, and she's been working in substance prevention for approximately 15 years. She's inspired by sociological theories and psychology to develop behavior change. She is also exploring the Icelandic model for years in relation so that it's adaptable to the Canadian political and cultural context. And then last but not least, we have Laura Crandall. She's a health promoter, also with Southwestern Public Health, who's been working in public health for 12 years. And over these years, she's developed a passion for collaborating with partners to build healthy community spaces through comprehensive policy work. Laura's background has been focused on tobacco control and smoke-free spaces. She has been involved in engaging community partners involved in youth substance use prevention. So now we are going to, without further ado, move forward with our presentations.
Good morning, bonjour, je m'appelle Natasha Baudet. I'm Natasha Baudet, and I am the lead for social prescribing with the Alliance for Healthier Communities. And I've been with the Alliance for about a year. And prior to that, I worked as a health promoter for about 19 years at Centertown Community Health Center. So as a health promoter, I worked on smoking cessation, stress reduction, physical activity like walking groups, chronic disease prevention, and I also was the lead for social prescribing. So today I'm going to talk to you a little bit about social prescribing, some of those unlikely partnerships we came up with, and finding health in unlikely places. So I'll start by telling you a little bit about the Alliance for Healthier Communities. So the Alliance is a network of over 110 community-governed, comprehensive primary healthcare organizations across Ontario. That includes community health centers, nurse practitioner-led clinics, Indigenous primary healthcare organizations, and community family health teams. These organizations share a commitment to advancing health equity through the delivery of comprehensive primary healthcare. They serve populations systemically marginalized and underserved by other parts of the health system, those who face the greatest barriers to health and the poorest health outcomes. These organizations are team-based and typically deliver a range of clinical, allied health, health promotion, and social and community support services. So this is our model of health and well-being. So all the work done by Alliance members is grounded in this model of health and well-being. So it includes community development, interprofessional, population needs-based, anti-oppressive, and culturally safe. And our Indigenous primary healthcare organizations use the holistic model of health and well-being. So I think most of us know that our healthcare is only a portion of what makes us healthy. And social prescribing looks at all those other aspects, all those other things we do that contribute to our health and well-being. So if you want to take a moment and even reflect on something that you do that helps you feel better, that is not part of your healthcare service. So it could be a walk in nature. It could be spending time with family or friends. It could be spending time with your pet. It could be a craft or a hobby or going out to see a concert, all those things that contribute to our well-being. So that's what social prescribing is. So I like to use the definition of connecting people with programs and services that are non-clinical, that support their health and well-being. So that could be food security, that could be income security, that could be transportation, that could be access to the internet, that could be arts, culture, music, social connection, peer support, bereavement groups. It can be many, many things. So I'm going to tell you a little bit about, just briefly, about our social prescribing journey here at the Alliance. So we started in 2018 with our social prescribing pilot. We worked with 11 different community health centers across Ontario, so rural, northern, urban, francophone, and social prescribing looked a little bit different in each community. Links to Wellbeing, which started in 2021, is a partnership with the Older Adult Centers Association of Ontario. This project is designed to help connect socially isolated older adults with community programs and services offered by seniors active living centers across Ontario. Older adults get connected through their primary healthcare provider, and we currently have about 60 senior centers and 200 healthcare providers on board, including 20 of our member organizations. So Black Focus Social Prescribing started about a year ago. We're working with 4 community health centers to develop a social prescribing model that is grounded in Black and Afrocentric values and principles, with a focus on supporting families and children. We're asking how we can make social prescribing culturally safe and decolonize aspects of the healthcare system to improve health outcomes for Black people in Ontario. And our newest project is Social Prescribing for Better Mental Health, which is funded by the Public Health Agency of Canada. We're working with 28 sites to improve social prescribing pathways. We're developing resources and tools to be shared and used by sites such as screening tools, intake templates, client surveys, and more. And we're sharing best practices across all of our projects. We are engaging our sites in co-design of an online learning module about equity-focused social prescribing, which will be widely available in November. So very briefly, we had some very positive impact on our clients through our evaluation of social prescribing. We heard very good things from our primary care providers, including that for those who were frequent users of primary care, once they were receiving the support of social prescribing, their primary care visits decreased. And a quick quote from a client. So, since joining the senior center, he participates in chair yoga, group fitness, and line dancing, adding that following the sheer enjoyment of line dancing, he leaves the center feeling like he's walking on a cloud, which is how I hope you will leave this presentation, feeling like you're walking on a cloud. So I'm going to just get right into some of the partners we worked with social prescribing. So if social prescribing is intriguing to you and you'd like to get started, here are 3 partners that are just very easy places to start. So 211 is a great place to connect with community and social services, available to everyone in Ontario. The Ontario Caregiver Organization has a 24/7 hotline for caregivers. They have training, they have webinars, they have all kinds of supports for caregivers. And the Older Adult Centers Association of Ontario can help you connect with the senior center that's closest to you. So these are some easy partners, easy ways to get started on social prescribing. I'm going to tell you also about some of the other kinds of partners I worked with. So here's some of our non-traditional, maybe these wouldn't come to mind as immediately as health partners, but for example, I'll give a few examples. So we had a walking group in Ottawa that would always start, attendance would start to dwindle around November when it got colder and snowier out. That's when the walking group would kind of go dormant. So we were looking for an indoor space to deliver our walking group. And in downtown Ottawa, we could go to the Rideau Centre. It's a very busy mall, but we were trying to think of a place that was a bit less hectic. And around the same time, we heard from the National Gallery of Canada that they were looking to get more non-traditional patrons in the door. So we were able to talk to them and organize a partnership so that we could run our indoor walking group there. So on beautiful days, we would meet outside in Major Hills Park and walk outdoors. But if it was rainy or snowy or bad weather, we could go inside, and we arranged a partnership so that our group could walk through the halls. We didn't go into the galleries, but we could walk through the halls. And the interesting effect of partnering with the National Gallery was for many of our clients, they had never been in the gallery before, though they had lived downtown all their lives. And as they got more comfortable coming there every week, it became a place where they could belong. So then people would stay, have a coffee at the coffee shop. They knew that the gallery was free on Thursdays. It started to become a place for them. So people often came to the walking group mostly for the social connection. Secondary benefit was that they were walking, and then this third benefit of being in a beautiful space, beautiful architecture, having art around them, and becoming more comfortable with that space. Another partner we worked with was the Writers Collective of Canada. So they offer very accessible creative writing courses, and they offered peer leader training. So a few of our clients signed up to become peer leaders to run this writing group at our center, and it started just as the pandemic started. So having these virtual writing groups was actually a real lifeline for a lot of people. And because we were supporting our clients and taking the training and leading the group, and that was actually where we saw the greatest impact for improved mental health, was when people had a role. When folks took on a role and could contribute, that's where we saw the biggest impact. So that's a very positive experience. And even some of our peer leaders went on to support our BIPOC creative care circles. So they were able to kind of design the programs that met needs that they saw in the community, and be able to work with their own community using some of the skills that we supported them in learning. We also worked with the Ottawa Art Gallery, which is always free. So we would always invite clients to go, but there was something quite intimidating about going by themselves. So we would organize field trips together. We would meet at the door and then have a tour of the galleries and then do a creative art project together afterwards. And there was something about going with that familiar face of the health promoter and some of the clients who had been coming to the center, that just made it, again, accessible. This could be a place where I could belong. One of the first things we did when we started the social prescribing was we changed our lens a little bit, because we had a seniors tea drop in, and we said, it's always the same folks coming every month, and our funders kind of looking for new clients. So we canceled the seniors tea. But then if you start looking at loneliness and isolation as determinants of health, then you want the same people coming. So one of the first things we did was start a coffee drop-in, where people could just, kind of an entry-level gateway group where people could get used to leaving the isolation of their homes, starting to connect with other people in the community, and kind of get in the habit of going to groups. And then, with people knew each other through coffee connections, they would feel more comfortable going to this Ottawa Art Gallery or going to other outings or other groups. And then even small, very simple partnerships, like we partnered with the Museum of Nature. We did some field trips there, but they were also able to offer us some free admission. Similarly, the Ottawa Symphony Orchestra gave us sometimes free tickets for their concerts. And what we heard from our primary care providers, I would just go over to primary care and say, here are some tickets, feel free to give them out if you think there's clients who may be interested. And what I heard from the providers was, we had an appointment where I was telling the client, you have to stop eating salt, you got to start exercising more, you have to do this, you have to do that, you have to take your medication. It felt like I was kind of lecturing the client, but then at the end, I could offer them these free tickets, and it felt so good to give them something. And that, that's another thing we hear about social prescribing from the providers. It brings some joy back to their work and gives them, it feels great to be generous, I guess. And then the last example I'll just share today is, I did smoking cessation, helping people quit smoking. And we always had this walk to quit program. We had 2 running rooms in our catchment. And I'd always encourage the clients, they're running walk to quit. Here's a coupon. You can do it for free. You just have to go to the running room. And there was some barrier. People never went. Even those who were already running or quite physically active, they never quite went to join. So I worked with the Canadian Cancer Society in the running room to develop some curriculum that was more appropriate for our clients at the community health center. And then I was able to deliver that program. And that program, again, it's like, people came for the social connection. And then as a side benefit, they also reduced their smoking and took up exercise. So that was another great partnership. And then I guess like the main partnership is really that co-creation with our clients. So, talking to clients, what are the gaps you see? What are some programs you need? Would you be interested in volunteering to help, co-lead or help to design or deliver some of these programs? So that's where we started getting programs at my center, like Women Only Exercise Group or the Talent Optional Music Jam, the creative writing, which I already mentioned, and even just having friendly callers during lockdowns during the pandemic. So having volunteers step forward to make some of those calls. Sometimes when people were calling their doctors or nurses, it was really out of pure loneliness. So can a volunteer support them? So really that's where we saw the greatest impact, was when our clients kind of stepped in and took on a role. And I just have to give a little shout out to my health promotion colleagues at Centertown. So Laura Snow and Amy Wanamaker. So they're doing great work on social prescribing, and I'd encourage you to reach out to them and ask them about it. So just a little mention, the Alliance is working with the Center for Effective Practice. This is a resource for health professionals for social prescribing. It's there on their website. And I'll invite you, if you're interested in social prescribing, if this is piquing your interest, we have a provincial community of practice, which meets every second month on Zoom. In June, we'll be meeting in person in Toronto. And we have a national community of practice on social prescribing, which meets quarterly. All the information is there on the website. So thank you very much. Merci, miigwech, and feel free to reach out to me if you have any further questions. Thank you.
Welcome. My goal today is to try and describe how the Ontario AFC Outreach Program has involved a series of collaborative partnerships at the local, provincial, and national levels to promote aging well in the community. The Ontario AFC Outreach Program is a provincial knowledge translation and exchange program designed to support age-friendly community development in Ontario. The program is managed by the Centre for Studies in Aging and Health at Providence Care, which has a rich partnership with Queen's University and is funded by the Government of Ontario through the Ministry for Seniors and Accessibility. The main goals of the AFC Outreach Program are to strengthen community capacity, increase collaboration, and raise awareness about AFC activities, benefits, promising practices, and also to share that information and some of the principles. We actively support at the moment some 60+ local age-friendly community initiatives across Ontario. As I mentioned, I hope to discuss some of the strategies and benefits we've seen of these partnerships at the local or micro, the provincial or meso, or national or macro levels. At the local level, age-friendly community steering committees bring together diverse stakeholders. They're involved in the evolution of the plans, the approval process, their ongoing evaluation, implementation, and sustaining. These communities bring together a variety of stakeholders. This includes older adults, volunteers from other age groups, key organizations that might have interactions with older adults, and community advocacy groups, and representatives of the local municipal government. This has benefits to the many stakeholders. For example, municipal partners have a ready-built group of stakeholders to seek input into their own official planning around transportation, housing, and other issues. And likewise, the representation of municipal members at the planning process around age-friendly initiatives is likely to facilitate the process of approval of those plans. At the provincial level, we've been fortunate in working with the local age-friendly community initiatives to create some regional networks. There are now 4 in Ontario, 1 in the north, 1 in the east, 1 central, and 1 west. These networks meet regularly with meetings that we facilitate through the AFC Outreach Program. And those meetings are opportunities for individuals to learn from each other, to have a regular dialogue, and to hear about some of the strategies around the provincial planning and evaluation of AFC activities. As mentioned, we're funded by the Ontario government through the Ministry for Seniors and Accessibility, and we have regular monthly meetings with staff, which again give us opportunities for bi-directional communication and collaboration. We have a number of relationships with researchers and educators, both in terms of individuals and at the university and working group level. This enables us to flag some of the best practices around age-friendly communities and to disseminate that information readily to the communities we link with. We're also involved with a number of provincial organizations, One such example is the Elder Abuse Prevention Ontario, where we've been able to work together over the last few years in seeking to align some of our work and activities to ensure integration and incorporation of elder abuse prevention strategies into the AFC action plans in Ontario. At the national level, we are fortunate to be members of a age-friendly communities reference group, which is chaired by the Public Health Agency of Canada. And that brings together provincial and territorial expertise and activities around age-friendly communities, enabling ready access to information and sharing at a provincial level. But also part of the World Health Organization's global network of age-friendly citizen communities. And that has given us opportunities, for example, to seek to align some of the provincial recognition programs to the global network strategies. So over the last 8 years, the provincial outreach program has been active, as we've mentioned, at the local, provincial and national levels. We've had the opportunity to learn from a variety of different interactions. We've noted that it's important to have all the voices at the table. That it's important to engage users and key stakeholders in shared leadership roles. That at the local level, it's really important to have a variety of stakeholders as well as municipal partners together in that relationship. That any of these planning activities require some infrastructure and support, so that this may be an individual or group who takes on the role of facilitating and ensuring communication and collaboration. That to be effective, we believe the strategy requires connections and partnerships at the macro, meso, and micro level, as we've discussed. There can, on occasions, be challenges in negotiating competing priorities. We saw some of those challenges during the recent pandemic. But it's an opportunity to discuss each partner's priorities and seek common opportunities and common goals that we need to identify with each partner contributes. And this may be a dynamic process that changes as resources change. That it's important to have formal processes and infrastructures like terms of reference and memorandums of understanding. And that it's essential to any effective process if we continue, that we need to continue to promote each other's work. That's the finish in terms of my formal presentation. We'll be happy to continue the dialogue and communication. We can be communicated with through our website at www.agefriendlyontario.ca. We have an active e-newsletter which you can sign up to receive communications. And we also have an active presence on several social media. Thank you.
Great, thank you. We're now going to move to our final presentation, which is by Planet Youth, Building Community to Prevent Substance Use in Youth.
Good morning, everyone, and thank you for having us here today to talk about our experiences with intersectoral collaboration applied to the Planet Youth model. Very briefly, Planet Youth is an evidence-based, population-wide primary prevention process. The model is designed to have a long-term impact on communities by reducing youth substance use. Instead of discussing the facts and faults of alcohol, tobacco, and other drug use with adolescents, Planet Youth takes an upstream approach that is focused on changing the environment. The model is based on data-driven solution making, where students within the local community complete a comprehensive survey looking primarily at substance use and protective factors. Data is analyzed and reports are ready for the community within 6 to 8 weeks. The quick processing of data makes sure that the information is relevant to the local community and that the findings are something that can be acted on immediately. Intersectoral collaboration and stakeholder engagement is a foundational piece of the Planet Youth model. Working with municipalities, schools, community and youth-serving organizations, and sports clubs to change the environment that children and youth are growing up in by increasing protective factors, and reducing risk factors so that they will be at a lesser risk of using substances. The image here describes some of the key partners from different sectors that are integral to have around a Planet Youth action table. Understanding that each partner plays an important role in the community and that together there is collective impact. Some examples of partners that we are currently engaging with include community serving organizations, mental health professionals, school board research and ethics professionals, civic and volunteer groups, elected officials, parents and caregivers, as well as city staff.
So what are some of our successes? Using materials and reports like the Canadian Centre on Substance Use and Addictions Cost and Harms Report helps paint the picture of how much we spend and why building a strong community around children is the healthiest and most cost-effective way to promote well-being for the future. There has also been a lot of information and research promoted around risk and protective factors, ACEs, and positive psychology. Consider the knowledge translation needed with stakeholders to ensure that everybody starts at a mutual understanding and agreement on these concepts was very important to us and our success. Another key success has actually stemmed from the pandemic. Conversation and drive around data-driven solution making has become more of a request and a comfort for our partners. As well, when we face resource scarcity, like in a pandemic, partners pull together and determine collective action. This can create some synergies between groups where amalgamation is formed and people look at common goals and objectives. So speaking from a lens of collective impact is very important to us. Another piece is to obtain a high engagement within the committees and work. We need to consider that our partners have their own contacts and engagements that lead to the further connections of other stakeholders like politicians and decision makers. Building skills within your group helps lead them to embracing conversations and expanding the supportive network through warm transfers. We've seen this locally, where our community members at the table have met with local MPs and city managers at other events to come back with conversation and meetings planned to further the engagement at our regional action table in support of this work.
It's always nice to hear about the successes, but of course there are challenges that we face throughout the process of engaging community partners, both internally and externally. The first challenge listed on the slide is probably one that many of us working in rural or mixed urban-rural parts of the province have had experiences with. The smaller rural communities just don't have the same level of resourcing that larger urban centers do. This includes municipal funding and staffing, as well as local community organizations and infrastructure. In the Southwestern Public Health region, we have a mix of small cities such as St. Thomas and Woodstock, along with many small rural towns throughout Elgin and Oxford counties. It's a bigger ask for these smaller municipalities to dedicate resourcing. The Planet Youth model requires a 5-year commitment, recognizing that any positive outcomes will not be seen in the short term. Obtaining long-term commitment from system structures that cycle annually through grants or through elective processes can also become problematic. Tied to this is the capacity limitations on staff within organizations that may sit on 2, 3, or 4 committees, all with overlapping priorities. Another challenge that we've encountered when working with organizations and community partners is moving beyond individual level solutions and preventing lifestyle drift. So falling back into the way that we've always done things. To help mitigate this, it's important to really spend some time increasing knowledge and building capacity to look beyond individual level interventions and consider the full stream and how all levels work toward the common goal of preventing harms from substance use. There's also been some hesitance from partners around the adaptability of the model as it was pioneered in Iceland. Many partners and municipalities also prefer to see the model in action prior to jumping on board. And finally, there's a drive to use data, but a need to work alongside researchers to understand what can be done with the data and how we can implement evidence-based solutions from that data. We have found that there is a disconnect between researchers collecting the data and those working on public policy. So finally, I think it's important to just mention that progress is rarely a straight line, and there are always bumps in the road and curveballs thrown. So it's important to always be ready to pivot with the same end goal in mind.
Some of the advice that we have gathered to this point is that it's key to think about all levels, local tables, regional, provincial, and national, when it comes to our partners and stakeholders. They all may have a vested interest in the project, and when we think about those levels of partnerships, we need to think about the advocacy that can happen from the bottom up and top down simultaneously, including the internal buy-in at all of those levels. Spreading the word, as you may never know whom your messages will reach through the connections of the people around one table. So building those local champions and the networks, your message can be transferred to make the work move so much faster than what you originally planned. Be prepared to pivot and move with the ebb and flow of policies that come forward, funding, partners, all heading towards the same goal, but with potentially a different avenue. This has certainly happened with partners at our local tables receiving a 15-minute presentation, which then exploded into more community conversation through those partners engaging, as well as a federal announcement with funding and other levels all coming together at the right window of opportunity, where we were required to pivot in the direction of how fast we are moving forward as a community action table. Third, we want you to look at the spark that will speak to each of the stakeholders that you're working with. Find out what their priorities are and how your goals can align. The most important factor for trust judgment from our partners in these various contexts is your integrity. So knowing that you're playing from a win-win solution is very important. So looking and meeting their needs as much as you are trying to have your needs met. Competency is the second most important factor for that trust judgment with those partners, as they want to know that you are an expert and know what you're talking about when you're bringing these proposals to the table. And if you don't know, that's okay. You know where to source those resources, or you're bringing the skills to the table of that reliable, consistent partner that will bring the information as they need it, so that even if plans go sideways, you are committed to navigating those solutions with them. Effective collaboration is more likely to occur when participants have a clearly stated purpose based on the shared values and interests. It's important that we recognize that participating partners often place values on different things, and the aim of the collaborative work is to find common ground and to generate that collective action to improve health. Establishing this shared purpose allows partners to see how participation will help them to achieve their own mandates, as well as contribute to the larger good. Partnership should be viewed as that win-win situation where every party gains something. Be clear, concise, and understanding of those key concepts. As we mentioned before, having a solid understanding of upstream definition, strengths-based and equity was key for the work that we're doing, and we continue to reinforce that as we go along each step of the way. So having said all that, we'd like to thank you for joining us on this journey as we navigate collective impact and intersectoral collaboration. To solve complex problems, we expect complex solutions. They are nonlinear, and we need to work together to make those things great and successful. So thank you very much, and we look forward to further conversation.
Great, we're now going to move into our panel discussion portion of the presentation. So I'm going to ask all my panelists to join me. And we can stop slide sharing. Well, thank you for such excellent presentations. I'm going to kick us off, and I think we were actually touching on some relevant pieces right at the end there related to this first question. So what strategies have you used to work through competing priorities or conflicting perspectives of various partners, knowing that everyone is working to tackle a common issue? So I saw that being, I think, directly tied to what Jessica and Laura were touching on in their portion of the presentation of kind of finding those win-win solutions. But this is open to anyone to start tackling that question.
I think I can jump in here, just speaking a little bit about when we find our partners' common goals and work with them to enhance their own existing work plan. So when we start working with our partnership tables, that we're not coming in as this is a new direction and we're asking you to change your work plans, or mandates, but rather enhancing and finding that alignment to be able to move forward with those goals and meet their needs just as much as we meet ours within the work that we're doing. So in the beginning, ensuring that there is that common understanding of those key principles and goals that we're headed towards, but that we're finding that that strength and cohesion within the work that they're already doing, right? So I'd say that.
Does anyone want to add to that?
Maybe I can share a little bit. Like, I think it's not so different from doing that kind of community development work or collective impact where you have multiple different kinds of organizations around the table or different kinds of people around the table with different perspectives. And I think it's like taking that community development approach. You're going to go slower. You're going to have lots of conversations, but you want to make sure that everyone feels heard. Everyone's opinion is taken into consideration. And so that, I mean, that's what I found. It's much easier to just be really directive and say, these are our 3 steps and this is how we're going to do it. Then you get the project done quickly. But if you want to get the project done well, it's taking your time, building consensus, hearing different perspectives, and really having some of those conversations that might take a little bit longer.
Any other thoughts? And I know, Emily, you're here representing Dr. John Puxey, so welcome, Emily Mullen,
Thank
to the
you.
discussion as well, and feel free to join in.
Thank you.
Okay, and then I'm going to move to one of our other questions. So one of the questions is just, where do you start? How do you ensure that you get the right people to the table? So we've been talking about how to draw in different partners, but like, how do you know, I guess, that you have the right people, and how do you draw them in?
I can start again. Some of the work, and we are really at that beginning stage with the work that we're doing locally here with the Planet Youth model, but it was to do a stakeholder analysis for our area and consider within those different partnerships and organizations in that stakeholder analysis that there's also the different levels, right? So the levels within that organization of who are the people that need to make the decision, or what is some of those kinds of outcomes. Because if you end up with somebody that it becomes like a telephone game of conversation, it can really hinder that process as well. So really kind of thinking about what you want out of the table that you're building when you look at your stakeholder analysis, to then look at that organization and figure out what level of it that you would need to be bringing or asking to join your table. Or if it's a different person, the expectations of that communication and what that looks like. So that's something that we certainly worked on. And when it comes to like a provincial level with the work that we're doing, it was really seeking out the common goal that we needed to have a momentum of the number of health agencies that were on board, because we're all funded to do substance prevention work, which is quite unique. A lot of agencies are doing more of the treatment and harm reduction kind of aspect of it. And so having that weight of we all get funded to do prevention, let's have a conversation, let's try to onboard as many of the public health agencies and community drug strategy tables as we can, to be able to be open about that conversation at a provincial level. So
I was just going to add, Jess mentioned in the presentation as well, some of those partners have joined or are beginning to join because of those warm transfers, or kind of happened organically throughout connections that were made from partners that were already existing and then going out and doing their own networking, and finding, people that are interested in the work that we may not have had connections with. So some of that organic partnership development has happened as well.
So maybe some early kind of champions as well, I'd imagine, who then went out and spread that message further, and like you said, had larger networks. Mhm.
Absolutely. Yeah.
Maybe I can add something. So, oh, sorry, did you want to go next?
No, it's all right. You go first.
I was just gonna say when I found when I'm looking for partners, I go where the energy is. So like a good example is the National Gallery. They were looking for non-traditional patrons. We were looking for a place to exercise. Another example is we worked with TO Live with our Black social prescribing because they were presenting the kink in my hair. And so we were talking to them, can we get some tickets for some of our clients? And it was an easy win because they were also trying to get, those non-traditional patrons, getting people out. So sometimes there's been a few places where I call and they don't seem interested. So it's not the right time, sometimes. So just going where the energy is can be helpful.
Yeah, it's Dr. Buxton. Sorry, I've been present, but I couldn't get any video contact for a while. Champions are really important in the age-friendly community groups. And those champions come from a range of backgrounds, but particularly older adults. And it's the idea of building that energy and building that involvement. So a lot of the age-friendly communities across Ontario, they start from a variety of small groups. It might be a public health organization. It might be a seniors advocacy group. It might be a municipality who start the process. And then it's through the engagement that they develop a common idea and common vision and a needs assessment. That's often where you start to build up some of those new partnerships as you identify some of those low-hanging fruits and look for opportunities where other people are moving in the same direction to leverage those. For example, a municipality might have their requirement to develop an accessibility plan or a transportation plan. Look for an opportunity to identify there's a gap for older adults and fit in with that official programming and hopefully leverage some of their resources.
Thanks for that, Dr. John Puskey. So I want to touch on something that Natasha spoke to there. So you said, I'm going to paraphrase here, but you knock on a few doors and there are going to be some that aren't interested. So what do you do in those cases? Like, is it a matter of, okay, it's not the right time to engage this partner? What if they're really, you see them as an integral partner from your organization's perspective, but they're hesitant or they're not interested? What do you do in that situation?
I guess one way I could answer that question. So thinking if there's an integral partner and they need to be involved, like one perspective is at the community health centers, we're working with like very much in community. So if we're working on a health project that's targeting a certain population, like let's let that group lead it. So, if we're working on Indigenous health, let's keep Indigenous health in Indigenous hands. It's the same with the Black social prescribing. We need Black leadership around the table to kind of be leading the conversation. And so, I mean, it's not quite answering your question, but I think it's so important to have that health equity lens. So I'm not going out and recruiting from other communities. I'm letting the community let us know what they need and how we can support them.
Any other thoughts?
I guess I could jump in again. So building the case. So sometimes it's the responsibility of the steering committee to really identify the need. So they have to build a case for why it's important to that other stakeholder group. And that's certainly been a role within the age-friendly outreach program. We played with age-friendly communities. It's helping by helping them build a business case. Particularly, it's crucial, for example, for municipal groups to be involved in age-friendly communities. So looking again for those linkages, looking for those opportunities to leverage. And it may take time. It may be a matter of an initial, well, we'll be willing to receive minutes or notes. If you could direct specific questions to them, and then hopefully increasing their engagement as the process evolves. So it is a dynamic process, but there has to be some gain for all the stakeholders in that process.
Yeah, I like what you said about the dynamic process there, John. So perhaps, you know, they don't have the time to commit a significant portion of, you know, they don't have a significant portion of their time to commit at this point, but then later on they'll become more involved as you continue to engage them in different ways, or as you build that case, as you said. So I think that's a good point. So let's move now to, we have all the right people at the table. How do we ensure that they're able to contribute in meaningful ways, knowing that there are differences in terms of capacity? So you might have smaller organizations that are really motivated and passionate about this topic, but can't contribute perhaps in the same ways that a larger organization with more resources can. So how do you ensure that they can contribute in a meaningful way?
I think one key aspect to that is ensuring that each individual or organization has an identified role around the table, and perhaps asking them what they are able to contribute rather than maybe assuming certain responsibilities. And recognizing that every organization and every player around the table has a different role, and it might be at a lesser capacity or a larger capacity, but identifying that role and asking them what is the level of contribution at that point in time, and then working with them as the project proceeds.
And just to piggyback off of that, with the provincial community of practice that I champion with the Icelandic model, every partner that might be at that table as you're building your terms of reference might have the different capacity to engage in different work that comes out of it. So while it started as a community of practice, this table has now kind of moved itself into a place where individuals are interested or invested in some collective and collaborative work for some key messaging and some like why recreate the wheel kind of content. And so, making it available that if you want to contribute, so having those like SharePoint resources that people can go in and contribute as they can, even if it's just to review the document that is being developed or the position statement or whatever is happening with that, so that they can contribute their voice in that aspect. So having those sharing platforms established for the communication to, especially because when you're community members or your partners work at different hours, work in different locations, having that has really expanded us to be able to connect across the country, even to have those kinds of sharing platforms for contribution.
Yeah, I think that's a good point. So also thinking about how you're facilitating their engagement in various ways, right? And acknowledging the differences, even in terms of those practical things that you mentioned there. So another, and so shifting a little bit, so talking about collaboration, often models of collaboration involve shared decision-making. Giving up control or sole decision-making can be difficult. It can be time-consuming or risky. So can you share any advice on how you've been able to navigate this?
I can just share historically, like I've done a lot of youth engagement work in the past, and I do see there's a comment there about youth engagement. Having a really robust strategy established from the beginning with your goal and the end goal in mind makes it more comfortable in those conversations of how partners need to navigate to get there, because we know that there's no linear path. Like in our presentation, we talk about like the pivoting and the directions and the opportunities that arise, like allowing our partners to navigate and and be able to get to those places, as long as we're all looking at that goal at the end. It feels very comfortable and very organic in being able to allow that process to happen. It does feel uncomfortable for some, and you have to constantly reassure, trust this process, because we all agree that we're still headed here, and it might not be in the same linear path that we originally laid out, but that's okay. We can expect that. So if you start off in that expectation of like, this might not land in a linear path, but we're all committed to this end goal. So yeah.
I can add to that as well, like having a project charter, and this is what our goal is. This is what we're working on. And we, like, I love this word iterative. We can go back, we can change it. Like we can kind of spiral back if there's something we need to change, but these are the kind of, this is what we're working on together. This is our shared communal goal that we're working on, and it's going to take some conversations. We're going to need to bring everyone up to speed. We're going to all get a chance to voice what we need to say, but this is our shared goal, and it's within the confines of the project charter or terms of reference, or however you want to kind of define what you're working on here together. We have a collective goal. And yeah, it's just having those conversations to decide how we get there. What are we doing?
All right, so then I'm going to ask you one more question before we move into our audience Q&A portion. So this one, again, some of you touched on it. Certainly, I know, Natasha, you had a slide there. We're talking about non-traditional partners. So are there other kind of examples of non-traditional partners that perhaps you've engaged in the past, or others you're aware of other projects where you've engaged? So I know, Natasha, you spoke to museums, galleries, you had a few specific examples there, which was excellent. So any other kind of non-traditional partners that folks should consider in the space of health promotion, knowing how broad that is?
One group that we haven't really started those connections yet, but they're on our radar during our stakeholder analysis of partners to connect with our community service groups like the Lions, Knights of Columbus, those kinds of organizations who are there to serve the community and oftentimes have funding and are there to bring that resources and positive solutions to their community. So that's one interesting group that we're looking into connecting with and working together towards some of these Planet Youth initiatives.
All right, so let's move then into our formal audience question and answer period. I know we've had a lot of questions flow in, and we encourage any participants on the line to continue submitting questions, and we'll keep pulling them together and asking them out. So I'm just going to look for our first question. So the first question is for Natasha. So can you talk more about co-creation of programming with clients and what this has looked like?
Sure, that's a great question. So even when we took on at the Community Health Center, when we took on that social prescribing, like the starting point was I did a presentation on what social prescribing was for all staff at the center and started asking them about some gaps that they saw for the kind of clients we see, the clients who face the most barriers. What are some non-clinical things that you could see supporting your staff? And then I did sort of the same presentation with some clients and some volunteers. What as clients, like what are some of the gaps you see that are non-clinical, like not medical, but that would help people with their well-being? And so when we talk about co-creation, we had a volunteer who was hearing impaired, and she said, oh, we've just all the social activities for hearing impaired folks in Ottawa have been canceled for the last few years. There's not, it's like, okay, that's a gap I wasn't aware of. Or same, the women only exercise group, Muslim women would prefer to perhaps exercise in their own space, like some of those things came from both staff and clients. And then we kind of asked our volunteers, or our clients, is there anything you have some energy or some skills around? So we kind of looked at the list of these are the gaps, and here are some opportunities. Is there anything that matches? And so that was where like some of our volunteers could take on leading some of those groups that filled in some of those gaps. So they helped us kind of design it. They helped us identify gaps and helped us select some programs, and then even helped us implement it. So I hope that answers the question.
Yeah, I think that's great. Okay, so then our next question here is for John. What challenges did you experience in helping to establish and facilitate regional networks for age-friendly communities? And you're just on mute there, so I'm gonna get you to unmute.
Okay, yes. Well, we were lucky in the age-friendly community outreach program. There was already an existing network, a fairly robust network, serving communities around the Hamilton area. We were able to use that as an example to reach out to the other communities. One of the things we were able to do, which I think was a good strategy, early on in the program, we started to look at factors that exist in age-friendly communities had found helped in terms of being successful and sustaining themselves. And we introduced the idea of an annual survey going out to age-friendly communities. That in itself was helpful, but what really built the strength for the regional networks was that we made the commitment to go out to the 4 geographies, take our team and all our information and share it with the local community and help with some of the travel costs to bring together the various age-friendly communities, some key stakeholders, academics who were interested in aging. And we shared the results of the survey that we'd done from some 80, I think it was 83 communities at that time. And we asked for their feedback. And we asked for their engagement in discussions. What should be the steps going forward for their community? And what was seen to be unusual to those communities was that the academics had actually come to them to ask for help and advice. And so that was very helpful because but we were naturally creating connections between age-friendly communities in the north and also in the east, in the central area and in the southwest. So we started the dialogue by going to them. And then as we continued that process of doing those annual surveys, we continued to feed it back to those individual networks so that we'd give them the information for their particular geography, as well as the provincial picture, so they had comparators. So it was through that sort of process of being willing to go out to people, hearing their information, their ideas, sharing our information back with them and adapting it based on their responses. And it's been a very, very successful process. So it's people like Emily Mullins, who's also on this talk, who actively support and facilitate those networks on an ongoing basis.
So it sounds like there was a lot of strengths, a lot of facilitators that kind of set that project up for success. And I imagine still some challenges that kind of emerged from that.
Well, actually, it's continuing to be a relatively robust process. We had some problems, obviously, through COVID, but we were able to fairly quickly take on the technology support side of the process. As I say, we've continued to do the annual survey. The information we receive through that annual survey is very relevant to the communities because we're naturally helping them with their evaluation progress so that they're able to see where they are compared to the previous year, but also able to see how they are performing relative to other communities that may be similar to themselves. So it's not been, for us, a challenging process. It's been a very
well, that's
rewarding
great
process.
that there's been a nice and smooth transition then. So I'm glad to hear that it's been a success so far. We're going to shift gears. I'm going to move over to Jessica and Laura and going to address one of our audience questions. So one of them is specific to your project. And how is Planet Youth different than other prevention programs, and why in this is collaboration so important or so crucial to it?
So I'll start and Laura can kind of jump in if I'm missing anything. But one of the biggest things that I just want to flag is the Planet Youth prevention is a model. It's not a program. So it's a model that's based off of sociological theory. So it was based off of the fact that there are risk and protective factors that can influence whether or not a youth uses substances. And if we can use data to identify where those risk and protective factors are, to then sit down as a community committee and develop localized solutions that meet the resourcing and the abilities of partners that are at the table to be able to make an impact at that local level, we see a more sustained and linear direction when it comes to substance use. So one of the biggest things that I always end up having to correct people is that it isn't a program that is run. Programs can come out of community tables coming together and discussing solution making. But at the socioecological level, we would hope that the strategy that comes out of your community table of looking at that data is not just at that individual or the interpersonal level, but would walk up even into the policy and the community level interventions that have a lot of weight in changing the social structure of your community and how people normalize substance use, what those policies like municipal alcohol policies, things like that would come out of some of the work along the way. So everybody kind of playing their role in the solution making, so at each level. So that's one of the big things that happens with the model. And right now, what typically happens with data is that lots of data is prepared, but there's a 2-year lag, typically, sometimes longer, before you receive that data. And Planet Youth data is a high turnaround point, but it's analyzed against with protective factors, which is one of the big things that we also do not typically do in a lot of our program planning work, is looking at those protective factors with the risks. We get a lot of reports just saying how bad it is. Yep, it's bad. We don't really focus in on what are the opportunities to enhance that will reduce the bad. So strengths-based, looking at those protective factors, moving forward with some of that work that can really scope in our communities and the work they do.
Yeah, I would just add to the data piece that turnaround time, I think, is one of the key pieces of Planet Youth that sets it apart, getting the data back within 6 to 8 weeks so that the community can look at the data that's relevant to the community right now and act upon it. So we're not looking at numbers from 2 or 3 years ago, but it's real-time data. The other piece I was just going to add is that it's that long-term commitment. So it's looking at a minimum of 5 years to see some results. So having commitment in the long term from community partners, and then going beyond that, probably 5-10 year kind of long-term look. And so that's one of the challenges too, because oftentimes it's difficult when you're working towards something and you're not seeing those results, which is common in our health promotion work. So staying the course, trusting the process, and committing to that long-term end goal.
Thanks for that, Laura. You're actually touching on another audience question that came in around just overall kind of sustainability planning and how do you address that? Because we know in this field, you know, it's grants-based, this short-term funding where the funders are asking you to turn around and show immediate results when some of these things are going to take a lot more work. So I don't know if any of the panelists have any comments about that challenge, I guess, of working in this space.
I can just share, I know Sarah Gill made a comment in there too about if we're onboarding, taking the time at the beginning to onboard and bring on partners. That's where we're still at right now, and really sitting in that when it comes to helping everybody get to the same level of understanding when it comes to behavior change and how long it takes for behavior change and the expectation setting of what that's going to look like, right? We can have some short-term quick wins indicators that you can kind of flag that make people feel good in that short term, that kind of meet the needs of science, temporary funding that kind of comes along that pops up, but it still moves you towards that goal. But letting them know that if our long-term goal is to actually watch substance use go, our alcohol rates in our region are 42% for our youth in grade 9. That's the same level that Iceland was at in 1995. And if we want to get down to a below 10% rate, that's going to take a substantial amount of time. And we often use the Smoke Free Ontario history and timeline to demonstrate the amount of different policies and efforts that had to be put in place and the years of work it took for us to watch those rates come down, to help our partners really visualize and see the contribution that takes and the collaborative work that needs to take to get there.
Great. Thanks, Jessica. Okay, I'm going to move to another audience question. This one is for Natasha. Are there any specific partnerships or aspects of social prescribing that you'd like to see grow in the years ahead?
Oh, that's such a good question. So, and because social prescribing is such a broad definition, it's anything non-clinical. So it can be food security programs, it can be income security, it can be housing security, it can be, it can be so many things that contribute to our well-being. I guess what I would like to see is just for it to become a more common way of working, that we look at well-being as a determinant of health. We look at loneliness, we look at sense of belonging. So wouldn't it be great if it's like having a bit of a longer conversation with a client to find out what matters to them and what are their goals and what's, so just taking that extra time to ask a few more questions. Any particular aspect? I don't know, because it's really very unique to each community. So some communities may choose to pursue different kinds of partnerships, and different individuals will find what works for them. And sometimes the path it's a little bit on a smaller scale, what Jessica was talking about, you can't always predict how it's going to get there. It's not always a linear path. But I would really encourage organizations to kind of open their minds to some of those non-clinical partnerships and see where it leads you, see where those conversations lead you, on an individual basis and at a community level. It can lead you places where I never would have expected that I'd be doing stretches at the National Gallery with people, and then people who knew me would see me and be like, did I see you leading an exercise group? So sometimes it leads you to places where you don't expect. I guess I'd love to see the healthcare system recognize this as supporting people's health and well-being in Ontario.
Thanks for that, Natasha. Okay, so I have a question you have an addition, John, go ahead.
Just make sure I'm not muted. No, I'm not. Okay, so I just wanted to echo that comment about healthcare engagement. As a clinician, as a practicing physician, I certainly believe in social prescribing. I have an advantage that I have a quite good access to a lot of information about available resources. But for a lot of physicians, they don't. And that's one of the challenges I think I find, is that people are not aware of the range of programs and services that are out there. And particularly in this, as we emerge from COVID, because even some of the available information on websites is inaccurate. The programs are no longer available, or they're delivered in a different way. So I think one of the challenges of moving forward with social prescribing is, how do we get a robust database of resources and services that are available and keep it current?
That's where I'll always recommend 211 as a great starting point, because they update their databases every year. And then, there's a few low-hanging fruits where we can reach out to that are more easy. And yeah, and I'll also add community-based healthcare, community health centers. We have some of those allied health professionals who can support like keeping up to date on those resources. And yeah, there's different models, but yeah, that is a good point. The things are changing all the time.
Okay, so John, we have a question that's coming for you. How do we find out who's working on age-friendly community work in our local communities?
Okay, well, that I can answer. One of the things we did do with the age-friendly outreach program is we built a database of existing age-friendly community initiatives across Ontario, and we list, based on the information we're given annually from the various initiatives through the survey I mentioned earlier, we update that. So it's available online. If you go to our website, you could go to sagelink.ca, www.sagelink.ca, and just enter in age-friendly communities. You'll see an option to go to maps, which basically by moving your mouse around, you can very quickly find the initiatives in your community. There should be contact information. There should be information about services that that age-friendly community is involved in. Maybe if Emily would be kind enough, and she'll put in the chat the link to the specific maps, geographic maps. Would you mind doing that, Emily?
Yep, I just put it in.
Great, I knew you would.
Great, thank you, John. That's helpful for folks looking to work on this. So I'm going to move to a question that came in for Jessica and Laura. Can you talk about the disconnect, if you see any, between researchers and policymakers, and then how do we bridge that?
Yeah, so that's one of the key pieces that really has been missing a lot too with other work around substance prevention, or even just some of the research that happens with universities and connecting back to agencies and organizations like community health centers and public health and things as we plan. One of the disconnect pieces is that the way that the funding system is structured around researchers and universities and such receiving grants and what they're tied to and what needs to happen to move that forward. We've been working with our school board research and ethics tables, and it all stems back to taking the time in those first initial conversations to really understand their work and the expectations on them and the asks of them, because with the school boards, they also have their own ministry that is directing the research that they have to accomplish. So they have their own check boxes of must do's. And so we work around, okay, so if these are the must do's in this year or in this time frame of this year, what's the practicality? Because we can't burn out our teachers, our school board support networks, and our students. The students have been surveyed a lot in 1 year. Pandemic really enhanced the amount of information collecting that was happening and things like that. So really working with them to understand their role and finding those connections. But the disconnect that has been most common from what I'm hearing of other health units and other partners that I've worked with is that we've actually never even reached out to talk. So making that first step to bring them to the table was the very first. We've just lived in two separate worlds of they're doing their thing over here and I don't even know how to connect with them, to opening up the door to say, I'm interested. Is anybody interested in this? So we do that. And we're starting to investigate that a bit more, even with some of our universities that are close by or that we know have done some substance specific work in the past, like with Waterloo and Western at the HEAL lab there and things like that. So it's more about taking the first step to reach out and let yourself be known that you're interested in hearing about the work they're doing and what you can do to maybe align better. I don't know if Laura has anything to add to that, but I don't have like a lot of solutions other than that's where we're starting right now. And we've learned a lot just from that. Yeah.
Thanks for that. Okay, I have a question that anyone can answer. We've been talking all about partnerships, of course, today. So are there any partner mapping tools or specific softwares or just practices that can help to facilitate, tracking who it is that you're engaging with, for example, who it is that's important to engage with? Anything you use currently? Or are we old school? Maybe we're just writing it out or creating a simple table.
I definitely don't know of any software, but I mean, a good place to start with social prescribing would be asset mapping. So looking at that, the strengths and resources already existing in your community, which could be like an Excel chart, doesn't have to be too fancy.
I just popped in the chat there. One of the software pieces that we use internally here is Lucid Charts, and you can design and develop your logic models, and we've done our stakeholder analysis in there, and there's a lot of templates already created, but it really makes it nice and easy, and they're visually appealing. I enjoy a nice, well-constructed logic model, so I really like using Lucid Charts.
Great, thanks for those suggestions. So I think we have time for one more question before we wrap up. So this one is just talking about how collaborations have kind of changed. So a lot of partnership development has changed since the pandemic. How has your agency, or how have you kind of been able to move forward? Like, are we getting out of that? I think where they were leaning from is just, we had to take a step back from in-person engagements, for example, during COVID. So any thoughts there?
I can jump in and just share that we are a rural health unit, and our partners are very disconnected from travel time. And so the opportunity to be able to have everybody connected through Zoom, through MS Teams, has really enhanced the amount of conversations that we've had. It's very quick dialogue right now. Like, we are working at doing a few in-person meetings, because there's a lot of body language and a lot of great stuff that comes out of meeting in person with some of our mayor, like we're meeting with the mayor and some of the city managers and things like that. But when you have somebody like your MP that it travels to Ottawa throughout the week and can't, we're actually being able to meet with her as partners coming to the table in a short turnaround time because of these online opportunities to be able to meet. And so I found that providing those options has really opened the floor from a youth engagement kind of perspective, because that's one thing that I don't want to lose sight of within the Planet Youth model, making sure that youth are not left off of the conversation and they are a key stakeholder to being at the table. We have seen the barrier of being in schools and connecting with them through their lunch hour, like so meeting them where they're at the school, but then finding out that afterwards they're just so drained or tapped out in other places, that navigating some of that youth engagement strategy is really where we're back at, like rebuilding that and figuring out what that looks like. Of like, are we going back over lunch hours in schools? Are we asking to meet right after school? Trying to figure that out for sure.
I think from age-friendly communities side of things, there was an initial problem in the first several months for the various communities as they tried to rapidly move to an online format. I think in the last year or two, there's been some successful translations, but I think it's a hybrid model going forward. But one of the problems I think we have to realize is there is still a big digital divide. If your community is rural, you may have very limited access to broadband. Older adults, traditionally, the number of people using internet is increasing greatly, but there's still a subgroup, the very old, the isolated, living alone, orphaned, various diverse populations, Indigenous groups, may not have ready access to the technology. So that's a challenge. So there's definite advantages. Now we have a greater awareness of virtual processes and Zoom, but we also need to realize we've actually created potentially a big barrier for the have-nots.
Can add to that. So I would say for the programs for clients, like, yes, it's hybrid now. And at our community health center, we were really fortunate to be able to hand out a lot of tablets and a lot of laptops and do a lot of how to use the internet training for for older adults and for all kinds of folks who hadn't been connected before. So for clients, things are returning to in person, and some people are finding they prefer the online for, for people with disabilities or for any number of reasons. It's so, being able to offer hybrid programming for clients. And then I think the advantage to hybrid is we are now accustomed to this way of meeting on Zoom. And I think I've been invited to lots of meetings that I never would have been invited to before. They wouldn't have been accessible. And so that's where you start having conversations and meeting other kinds of partners too. So yeah, I think I think the hybrid model will keep going. Like, I think we're going to stay this way.
Thanks for that. I just wanted to say thank you to all of our panelists today. And thank you, of course, to everyone who's been able to join us. That wraps up our question and answer period and our session today. So we do encourage you to complete the evaluation. You should see the evaluation link in the chat. You should also see it when you close out the Zoom session today. And stay connected with Health Promotion Ontario on Facebook, LinkedIn, and Twitter. So thanks so much, everyone. I hope we got through your burning questions. I know there was so many more that we didn't get to, but we encourage you to continue the conversation with Health Promotion Ontario. And thank you so much. Bye, everyone.